Rheumatoid arthritis is a chronic, progressive, inflammatory, systemic disease which is primarily affecting the joint. Now, the most common joints that are affected here includes the proximal interphalangeal joints. The proximal interphalangeal joints are the most commonly involved joints. Then the metacarpophalangeal joints are involved. Now, the important thing to note here is that there is no involvement of the distal interphalangeal joint, which is usually seen in case of the osteoarthritis. It is seen in case of the psoriatic arthritis. It is seen in the erosive arthritis, but it is not seen in the rheumatoid arthritis. That is very important thing to note. That the other thing that to be noted is that there is involvement of the carpometacarpal joint, commonly seen the styloid of the radius, the styloid of the ulna, and the carpal joints are involved. Also, there in the hand there will be tenosynovitis, which might lead to the median nerve compression, and the symptoms of the median nerve also will be there. Now, these are the small joints are most commonly involved. This is the rheumatoid arthritis having small joint involvement, the symmetric joint involvement, and also when the large joints are involved, it will have involvement of the shoulder and the elbow, knee and hip joints are involved. The axial skeleton is rarely involved. The axial skeleton is more commonly involved in the seronegative arthritis, but when the axial skeleton is involved, it involves the cervical segments of the vertebral bodies. In the cervical, specifically, the involvement of the C1 and C2 vertebral bodies are commonly seen in the rheumatoid arthritis, and temporomandibular joints are also commonly involved. When the rheumatoid arthritis involves the axial skeleton, the most common site of involvement is the place of the C1 and C2 segment and the craniovertebral junction. The structure that is commonly involved is this structure, that is the odontoid process of the dens, the odontoid process of the C2 vertebra with the involvement of the dens most commonly undergoing the erosion. There will be odontoid process will be undergoing erosion by the pannus which is deposited around it. There is pannus deposition around it which will lead to erosion of the dens, and because of this there will be damage to both the dens as well as even the arch will be damaged. Even the arch of the atlas, the anterior arch of the atlas is also damaged, and this will lead to the subluxation of the medial atlantoaxial joint. Now, along with this, there will be also the involvement of the facet joint. The facet joint will also be involved. The facet joint will undergo degenerative changes. There will be initially the erosion of the cartilage, and because of which either one-sided facet joint will be damaged or both the sides facet joint will be damaged. Whenever one side of facet joint is damaged, there will be pain on the ipsilateral side and there will be ipsilateral torticollis because of the collapse of the facet joint. Also, because of the damage in the transverse ligament which is holding the dens with the arch of the atlas, there will be the herniation of the dens into the foramen magnum, which can be seen by two lines, that is Wackenheim's line. It is nothing but a line going along the clivus. Normally it will touch the top of the dens, but if it is cutting the odontoid process, then it means that there is some sort of subluxation. So this is also called as atlantoaxial impaction. So there will be atlantoaxial impaction, there will be atlantoaxial subluxation, there will be erosion of the dens and also the arch of the atlas, and there will be the torticollis and the destruction of the facet joints, which will lead to unilateral destruction, leads to torticollis. Is the most common thing which is happens when the involvement of the cervical segment. Also, sometimes there will be lower cervical vertebral bodies are also involved, and when the facet joints are involved initially, the facet joints gets degenerated. Now all the weight is borne on the intervertebral disc. Eventually the intervertebral disc gets some degenerative changes. There will be irregularities in the end plates of the vertebral bodies. So these are the combined changes that we see in case of the rheumatoid arthritis. Summarizing everything, so initially there will be pannus formation, a thick pannus formation, which will appear as it is seen here, hypointense on T2 weighted image, hypointense on T1 weighted image. Contrast enhancement shows avid enhancement, and this will lead to erosion of the dens, erosion of the anterior arch of the atlas, and it will lead to involvement of the facet joint, irregularities in the facet joint, the impaction of the facet joint, the destruction of the facet joint. Unilateral involvement of the facet joint leads to torticollis, or it can have bilateral involvement with reduced neck movement. Also, it can involve the various levels of the vertebral bodies, where we can see the irregularities in the end plates of the vertebral bodies. So these are the changes that we see in case of the rheumatoid arthritis. In this lateral X-ray of the cervical spine, we can see that this is the C2 vertebral body, this is the anterior arch of the atlas, and we can see that this is how the presence of the odontoid process and the dens. And see this, the anterior arch is corresponding to the level of the body of the odontoid process, and the dens is moved slightly upwards, though the upper part of the dens is not clearly seen because of the mastoid shadow that we are seeing. But what we can see clearly is how the anterior arch is slightly away from the odontoid process, it's away from the odontoid process, and also it is corresponding to the body of the odontoid process and not the dens. Normally it is present at the level of the dens. Now the other thing that to know is normal distance between the anterior atlas arch and the odontoid process is less than 3 mm in adults and less than 5 mm in children, and less than 4 is usually considered as normal overall. Now whenever it is present more than 4 or more than 5 in children or more than 3 in adults, we consider that there is atlantoaxial subluxation. Now whenever there is atlantoaxial subluxation, there will be increase in the distance between the anterior arch of atlas and the body of the dens. Now other thing to know is that whenever this distance increases more than 9 mm, when the distance increases more than 9 mm, then this will lead to compression on the spinal cord, and it will cause symptoms of the spinal cord injury. So it will cause spinal cord compression, there will be the syringomyelia and myelomalacia, not the syringomyelia, there will be myelomalacia, there will be the spinal cord compression changes will be seen. Also note that there will be some vertical irregularities in the end plates of the vertebral bodies here, and also there is some anterolysis of the vertebral body, maybe because of the facet joint has undergone destruction, so because of which there will be anterior subluxation. But there is no soft tissue edema around. If there is soft tissue edema around, we can think of infectious cause of the spondylodiscitis would have caused, but there is no soft tissue edema. Also there is generalized osteoporotic bone is there, which is again classical feature of the rheumatoid arthritis. Again, if you see this CT image, we can see that there is completely destroyed the dens. Also we can see that there is some irregularities in the vertebral body end plates, and but there is no soft tissue edema around it. So again telling us that this is a mechanical stress which is causing this irregularity in the end plate and not the so whenever shoulder is involved in the rheumatoid arthritis, again the shoulder is a type of synovial joint, where when the rheumatoid arthritis is involved, initially the synovium will be getting thickened. As we see here, the synovium is thickened, and then initially the erosion happens in the marginal areas. It happens in the marginal areas because they are not covered by the cartilage like we see here, and or the periosteum like we see outside the joint capsule. So the inside the joint capsule there are some peripheral areas which are not covered by the cartilage as well as the periosteum, which are the earliest site for the involvement of the erosions. This is where the erosions initially start. Also later stages there will be thinning of the articular cartilage and subchondral erosions. There will be mild subchondral erosions, and once there is complete destruction of the cartilage, the entire subchondral bone can be involved. But initial stage there will be marginal involvement of the erosion. So synovial thickening starts with the synovial thickening, margin starts getting eroded because there is no cartilage or the periosteum. Then eventually the cartilage starts getting thinned out. Then the subchondral erosions will develop, subchondral cysts will be formed, joint effusion will be there. Also there will be the rotator cuff injury. And also there is a area where there is coracoid process here, and there is a clavicle here. There's a membrane going from the coracoid to the clavicle called as a coracoclavicular membrane. Now when ligament, the coracoclavicular ligament, now the area of this attachment of the coracoclavicular ligament of the clavicle usually undergo erosions, and that's what we can see in this picture. There will be erosions in near the attachment of the coracoclavicular ligament. Also there will be erosions in both the end of the acromioclavicular joint. This acromioclavicular joint, you can see that the space has increased. So that is because of the erosions that are happening at the level of the coracoclavicular joint. So because of it, there will be increase in the space between the coracoid process and the acromioclavicular joint space will be increased because of the erosions happening. Also in this image we can see here there is a glenoid. This is the head of the humerus. We can see multiple subchondral cysts, and we can see mild irregularities we can see here, and also the subchondral cysts are present here. Now if you see the image on the right side, what we can see is there is a loss of joint space. There is loss of joint space. Even in the previous image there was a loss of joint space. There is subchondral cysts are present. Also see, this is the acromial process. There is no space between the acromion and the head of the humerus. It's because of the chronic rotator cuff tear. The head of the humerus has subluxated upwards. Also we can see some erosions at the level of the neck of the surgical neck of the humerus, and now this is because of the erosions that are happening because of the chronic touching of the surgical neck of the humerus with the glenoid. When there is involvement of the small joint like that of the interphalangeal joints, the proximal interphalangeal joint, metacarpophalangeal joint, normally the joint contains a outer capsule. Now inside the capsule there will be a layer of the synovium, and then there will be the joint is lined by this cartilaginous substances. The cartilage will be present on either side of the joints, and there will be little amount of the fluid inside the joint. Now whenever there is inflammation of this joint, initially there will be thickening of the synovium. Along with that there will be increase in the joint effusion. So there will be increase in the joint fluid, so it's called as the joint effusion. So initially there will be synovitis with joint effusion, which will appear like widened joint space, and later there will be thickening of this synovial membrane, which in ultrasound we can see as a hypoechoic layer, which is showing increase in vascularity. Both the fluid as well as the thickened synovium, both will be appearing as hypo on ultrasound, but on color Doppler there will be increase in the vascularity. Also when this progresses further, the synovial thickening increases further, and also the space where there was no cartilage in the intra-articular surface, but there is it is present intra-articular. There is no cartilage covering also intra-articularly. Inside the capsule there will not be periosteum, because of which the erosion starts at the margins. There will be marginal erosions will be present. Eventually the cartilage gets damaged, like how we see here, the cartilage gets damaged, and there will be small erosions under the cartilage, cysts under cartilage, subchondral cysts, and once the cartilage is completely destroyed, the bone starts getting destroyed, and which will have this classical penicillin cup appearance, which is also called as arthritis mutilans. Along with this, because of the inflammation, increased vascularity, the bone is getting resorbed. Initially the subchondral area is showing the resorption or the osteopenia, and eventually the entire bone is filled with osteopenia or the erosion. So these are the classical changes in the earlier stage of the rheumatoid arthritis that we see. Eventually the ligament will undergo laxity, so there will be ulnar deviation, the olar subluxation of the joints, the ulnar deviation of the joints. There will be swan neck deformity, there will be botaniers deformity, the swan neck in the swan neck deformity there will be flexion, hyperflexion of the distal interphalangeal joints with the extension of the hyperextension of the proximal interphalangeal joints. This is called as a swan neck deformity. There will be Botaniers deformity, in which there will be the flexion of the proximal interphalangeal joint and the extension of the distal interphalangeal joint is called, with the extension of the metacarpophalangeal joint, is called as Botaniers deformity. And even there will be so many other deformities which is present along with ulnar deviation, the Z-shaped fingers because of the ulnar deviation at the wrist joint and the lateral deviation distally, and also there will be polar subluxation of all the joints can happen along with the ulnar deviation. So these are the changes that will happen commonly in the small joints. So this is an early stage of the disease in which we can see the soft tissue swelling in the hand. We can see also some amount of soft tissue swelling at the level of the metacarpophalangeal joint. Also the metacarpophalangeal joint space has been increased. This is quite early stage. Now as the disease progresses, but here there is no osteoporosis. We cannot see any osteoporosis or osteopenia. But if we see, compare that with this image, we can see some amount of periarticular osteopenia. Compare this with this bone, there is some amount of osteopenia is noted. Also see the space here, the space has reduced, here, so there is some amount of cartilage destruction. Also if you see this cortical margin which is not clear, this is nothing but the cortical the cortical is not clear with the classical dot dash pattern which is usually seen in the and some amount of marginal erosions are seen here. So marginal erosions with cartilage destruction is some early stage of the rheumatoid arthritis. In this image again we can see here some amount of the marginal erosions, the destruction of the joint space. There is osteopenia, the periarticular osteopenia, the marginal erosions, there is joint space reduction. Also here we can see the destruction of the proximal interphalangeal joint is noted. The other findings that is classically seen here includes this rheumatic, the rheumatoid nodules which is causing the adjacent erosions of the bones. And also if you see in this the metacarpophalangeal joint, the joint space destruction with marginal erosion is again a classical case of rheumatoid arthritis. If you see in this image again we can see here there is the styloid process. The styloid process is showing some erosions. Also some band like area of osteopenia usually seen in a rapid onset rheumatoid arthritis. This MR image again shows that there is erosions. There are erosions at the tip of the ulnar styloid. Also the triquetral bone. So there is erosion. Also we can see this is a T1 arthrogram. This is T2 FS image, and we can see here some amount of erosions noted in the scaphoid bone as well. Also there is slight thinning of the adjacent cartilage, so the involvement of the carpal bones are seen in these images. In the initial stage of the hip joint involvement, there will be the thinning of this articular cartilage will be thinning, and also if you can see that it is diffuse osteopenia can be seen in this image. Also we can see some amount of the cortical buttressing which is more on this side, and this is because of the secondary osteoarthritis changes. The other important thing that happens in the hip joint is one thing, there will be protrusio acetabuli, because of the weakening of the acetabulum the femoral head will be moving inside. The other thing that will happen is the fractures in the neck. In the femoral neck, fractures are commonly seen. These are nothing but an insufficiency fracture. The other place where we see insufficiency fracture is seen in the bisphosphonate therapy patients who is on bisphosphonate therapy, in which we can see subtrochanteric fracture on the lateral aspect. Subtrochanteric fracture on the lateral aspect is usually seen in bisphosphonate therapy. The neck fractures in the femoral neck, the medial aspect, the femoral neck fracture is commonly seen in case of the rheumatoid arthritis of the hip. So as the disease progresses, we can see that the pannus keeps becoming more and more thicker, and there will be loss of this cartilage. There will be bone marrow edema around this the place where there is loss of articular cartilage. And whenever there is loss of articular cartilage, we can see in this image it is uniform loss of articular cartilage, unlike in the osteoarthritis where there will be involvement of the superior portion more commonly involved than the rest of the places. In this image we can see that there is loss of articular cartilage. There is second osteophytes formation. There is secondary osteoarthritic changes. There will be diffuse osteopenia if you see the bone, but around the joint it's more of the osteoporotic changes, as osteoarthritic changes have started developing. Also, if you see in this image, what we can see here we can see there is erosions in the hip joint. Also, we can see the fluid the decompression of the joint fluid will happen with the fluid going into the iliopsoas bursa, and that's how the fluid is accumulated there. In this image, if you see here, there is this gluteus muscle which has ruptured, and there is a fluid accumulation here. So there is a rupture of this. The gluteus tendon is noted, which is also commonly seen in case of the hip joint involvement in the rheumatoid arthritis. Now in this image we can see that there are some insufficient fractures. The medial aspect of the neck of the femur, shaft of the femur also is seen here. So when it comes to the knee joint, all the findings are again same. There is diffuse osteopenia, there is the decrease in the symmetrical decrease in the joint space, and also specifically there will be involvement of the suprapatellar bursa, like how here you can see the fullness of the suprapatellar bursa, and also we can see the erosions like we see here in the infrapatellar erosion, and also small erosion in the marginal. Again, erosions here are the marginal erosions, and also whenever the knee joint is involved, it is having trilateral involvement, that is all the three compartments of the knee are involved. On MRI, what we can see here is that there is a diffuse synovial thickening and enhancement of this synovium, which suggests that there is the synovitis, and also these patients we can see that there is some suprapatellar bursal effusion. And to decompress this the synovial the fluid, usually there will be formation of the Baker's cyst or the popliteal cyst will be formed. Once the ligament and the capsule is involved, then there will be this kind of the subluxation of the joint because of the laxity in the ligament and the capsule of the knee joint. When the foot and ankle is involved, again we see the same findings. There is erosions, the erosions, marginal erosions, but the most common site of involvement of marginal erosion is the fifth metatarsophalangeal joint. This is the most common site of the marginal erosion, as we see here some marginal erosions are seen. And also in this image we can see some amount of indistinctness in the fourth metatarsal head. We can see the head, the margins are indistinct, again a feature of the rheumatoid arthritis. Now other features that we can see here in this image is the posterior calcaneal tubercle erosions, but this is not specific for this. This can be seen in psoriatic arthritis or the chronic reactive arthritis, also show this, the posterior calcaneal tubercle erosions. Other than that, we can see here the erosions of the second, third, fourth and fifth metatarso phalangeal joint erosions with the reduction in the joint space. Also we can see the interphalangeal joint erosions and irregularity. In the previous image we saw the fourth and fifth interphalangeal, the metatarsophalangeal joint involvement with fifth metatarsophalangeal joint erosions. Corresponding MRI also shows the joint effusions with erosions of the fifth metatarsophalangeal joint and surrounding edema, and joint effusion in the corresponding fourth metatarsophalangeal joint. This image we can see that there is a soft tissue intensity mass lesion which is appearing slightly hyperintense in some areas, and also some amount of the joint effusion which is lifting of the one of the tendons which is present above the fifth metatarsophalangeal joint. And this joint effusion, this appearance on contrast enhanced imaging, we can see there is intense enhancement of the synovium of the metatarsophalangeal joint. Also there is peripheral enhancement of this soft tissue mass, which is nothing but an inflammatory mass which is seen in the rheumatoid arthritis. So these are the features that are seen in the foot, ankle and the foot. Along with this, there can be one more finding, that is the pre-Achilles bursitis. There is a bursal fluid in the pre-Achilles region. But the most common joint which is involved is the fifth metatarsophalangeal joint involvement with erosions. The fifth metatarsophalangeal joint erosions are the most common finding. And also there will be osteoporosis, generalized osteoporosis, and because there is generalized osteoporosis, there can be insufficiency factors. So overall in rheumatoid arthritis, if we see, there will be inflammatory exudates which are coming and filling inside the synovium, leading to synovial thickening, which is an avidly enhancing synovium which is appearing hypo on both T1 and T2. Along with that, there will be joint effusion which is appearing hyper on T2. Now this will lead to marginal erosions initially, cartilage destruction, reduction in the joint space, subchondral cysts, subchondral erosions. There is indistinctness of the margins with dot dash patterns of the margins of the cortical bones, and some rheumatoid nodules, bone marrow edema, the subchondral cysts, and generalized osteoporosis, starting with the periarticular osteopenia, which will finally lead to generalized osteoporosis. This is everything about the rheumatoid arthritis. If there are all the features of the rheumatoid arthritis except that osteoporotic changes, and there are large subchondral cysts, and if there are large subchondral the cysts like we are seeing here, if there are large cystic areas, then this is called as a robust rheumatoid arthritis. We can see large cystic areas, the subchondral cysts are large, but there are no osteoporotic changes. Now this is what we see in case of the robust rheumatoid arthritis. This is a patient who is showing the erosive changes. Also we can see the protrusio acetabulae here, along with the enlarged spleen, the splenomegaly, and also there is neutropenia. So this is a case of a Felty syndrome. So rheumatoid arthritis patient along with neutropenia and splenomegaly is called as a Felty syndrome. Again, there is one more patient, abdominal X-ray showing the splenomegaly. On bilateral foot X-ray, we can see the erosive changes with reduction in the cartilage, the joint space, and the destruction of the cartilage of bilateral lower, bilateral symmetrical involvement of the fifth metatarsophalangeal joint, the classical involvement of the foot in the rheumatoid arthritis, along with the splenomegaly, is a case of a Felty syndrome.